Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Forden, and I'm the chair and organizer of Grand Rounds. Last week, we were in a hybrid Grand Round at the Ronald Howden lecture with Jen Cleland. We had a record attendance of over 50 people in the room and around 95 online, so we were breaking records. Last time we had more than that was the week before COVID, where we talked about COVID, where we had over 200 people in the room, the heady days of the pre-COVID world. This week we're back to just online, and obviously you may be watching this on the YouTube channel afterwards. And if you are, then you're very welcome. We have over 1,000 subscribers to our YouTube channel now. I don't think I'm going to be able to retire from the proceeds of it just as yet, but it is nice to see that we get a lot of views on the YouTube channel as well as people dialing in live on a Thursday. It is Antimicrobial Resistance Awareness Week, and so Helen Kellaby and colleagues asked me a few weeks ago if they could take this slot to talk about antimicrobial resistance awareness. But we're going to start off with just a 5-minute slot from colleagues Ronan and Mike, who are going to just explain to us the rationale for a change that's coming in for well, you see on the screen, transition from deltaparin to enoxaparin. And when they're done, we'll crack straight on with Helen and the colleagues for the infection chat. So, is it Mike or is it Ronan?
I'll go.
It's Mike. On you go.
Brilliant. Thank you very much. So this is going to be a whiz through because we don't have much time, but I just want to talk about the transition from deltaparin to enoxaparin, which is happening on the 1st of December 2025. So Monday week, we are going to be changing to enoxaparin as our first line low molecular weight heparin in NHS Tayside. And why are we changing? We're changing because enoxaparin is now more cost effective. The price of deltaparin went up, enoxaparin came down slightly, and it makes it very, very expensive not to change. So most trusts in Scotland and England are now going to move to enoxaparin as their first line agent. Key facts about enoxaparin: the brand we're going to change to is called Inhixa. Because it's a biosimilar medicine, it should be prescribed by brand name. And Inhixa is just a biosimilar, effectively a generic version of the originator brand, which was Clexane. The licensing is pretty much equivalent across the two of them. So we will just be using like for like. And like I said, we'll be changing on the 1st of December. So not long at all now. The dosing for enoxaparin is in milligrams rather than in international units for deltaparin. So that's the biggest change. And there's some dosing information that's been agreed with MAG now that will be sent around probably the end of this week. So have a look out for that. And it basically gives you the prophylactic dosing of enoxaparin, and then we've done dose bandings for the treatment dose. There are two treatment dose schedules, one for kind of your standard patients and then one for high risk patients. Obese patients are slightly complicated, so there's a separate section for that. That's why I put a star next to that in the high risk patients. But otherwise, cancer patients, recurrent VT, proximal DVT, symptomatic PE should all get the higher dosing of 1 mg per kg twice daily. The standard dosing being 1.5 milligrams per kilogram once daily. So this is just an example of the table that you'll find in the dosing information, like I said, that will be sent around and also attached in the formulary. So please refer to that. We're not wanting people to work out the equivalent doses. If you see, so don't think, oh, I'm on this much deltaparin, that's equivalent to this much enoxaparin. We want people to just have the dose calculated for the patient based on their weight and their renal function. And so the key with the dosing is if the creatinine clearance is less than 30, they get the renal dosing, which for treatment dose is 1 milligram per kilogram, and for prophylactic dose, come on to here, prophylactic dose is 20 milligrams for renal patients, and the standard prophylactic dose will be 40 milligrams once a day. There is some monitoring that can be done in renal patients, so that will be included in the guidance anti-10A levels, but we're not suggesting that's routinely done for any other patient population because there just isn't enough evidence to support anti-10A levels done routinely. And like I said, the standard prophylactic dose is going to be 40 milligrams once a day. So clinical teams need to be aware that we're changing, and any guidance that mentions dalteparin needs to be updated to reflect enoxaparin, and ideally just generically say refer to the formulary for dosing information rather than putting specific information about enoxaparin in it. Just say use the low molecular weight of choice for NHS Tayside, because that will kind of future-proof it for if we have to change again in the future. And then next week, we're going to ask teams to start thinking about having the dalteparin to stop on the last day of November, so that'll be the 30th, and then having enoxaparin ready to start on the 1st of December. So because we've got HEPMA, we can kind of do future prescriptions. So from the 1st of December, every patient should be on enoxaparin. The only caveat to that would be if it's a very complicated patient where there's been monitoring done of anti-10A levels or anything like that, then we can keep them on dalteparin. But the 99% of patients are going to be moving over to enoxaparin. And then the dosing information will be coming out this week via whatever communication channels we can. We'll just cascade it down, but it'll also be on the formulary. Please email me if you have any questions. Thank you very much.
Right, thank you very much for that. All very straightforward. I predict there'll be a slight bit of carnage on the 1st of December, but these things pass very quickly, and we'll all soon be very used to writing a different low molecular heparin. So we'll move straight on. Helen has started sharing her screen.
Ready and raring to go. Can you see that okay?
Yeah, do you want to go to the presentation mode and we'll just make sure we've got the right thing?
Is that okay? Moving okay?
Yeah, it's perfect. So, with no further ado, I'll hand over to Helen and her colleagues.
Okay, thanks very much. So we're here to celebrate or mark World Antimicrobial Resistance Awareness Week. So this is a few of our colleagues who I will let introduce themselves as we go on, but on behalf of the Infectious Diseases and Medical Microbiology team. So what we're going to talk to you today about is what exactly is AMR, how are we doing locally, how are we doing globally, and then Becky's going to present to you a case of last resort before Anna goes on to talk about the NEA's AMR framework. If you've got any questions on any of these sections from us, we'll take them all at the end, just on the interests of time. So what exactly is antimicrobial resistance? You've probably heard the term lots. Some of you will know exactly what it is. Some of you probably won't know very much about what it is, but it basically means any kind of bacteria, virus, fungi, or parasite that changes over time and then becomes no longer able to respond to antibiotics. So for most of this talk, we're talking about antibacteria, about antibacterial resistance, but it does encompass viruses, fungi, parasites as well. Means infections are harder and harder to treat, and there might only be IV options. They might only be able to go on OPAT or be in the hospital, or indeed they might have no options to treat at all. And I think it's quite common to think, oh, that's an ID problem, that's a micro problem, but this is going to affect lots of other specialties much more than it'll affect our specialties. So when you can't use any antibiotics anymore, elective surgery becomes very, very high risk. Chemotherapy becomes very high risk. So other specialties, hematology, oncology, orthopedics, general surgery, obstetrics, affects everyone. So what is the problem? Joanna will go into much more detail about what the problem is globally, but to give you an overview, the annual deaths that are directly attributable globally to AMR is over 1.14 million. And there's just been a report come out from UK HSA, which covers England, saying that superbugs, which is effectively AMR, it's just what the media like to term it, rose 17% in the last year. So I want to show you really what the problem is here and what we're doing and what you can do to help combat this problem. So this graph, don't worry, I've only got about 3 graphs or so it shouldn't be too much of an overload. But this shows us our health board. So it shows us Tayside versus Scotland, and it shows us how many antibiotics we're using intravenously over time. And we're using that time period as 1,000 acute bed days. So you can see that the black line is all of Scotland and how they're doing from 2013 to 2025. And you can see the purple line is Ninewells, blue line is Perth, and the grey is all of Tayside. So we're actually using probably more more IV antibiotics than the rest of Scotland. So one thing that you can do if you want to help combat AMR is reviewing IV antibiotics daily. So making sure, does this patient still need to be on antibiotics through the drip, or can they change to tablet antibiotics now? Now, this is really well demonstrated by metronidazole. So this is a graph of metronidazole showing IV use in the green line and oral use in the blue line. And you can see that there's been a campaign from the team. Our pharmacists and our antimicrobial group have been working really, really hard to try and make sure that all metronidazole, if it can be, is given orally rather than IV. And that's because metronidazole has a really good oral bioavailability. It's about 95 to 100%. So there shouldn't really be a reason that they need to have it intravenously, unless, of course, they can't take things via the oral route. So we can see we're starting to plateau a bit just at the end. So that's a little plug. You can do it on HEPMA. Just try and make sure that as much as you can, tablets are taken, metronidazole is taken orally. Now, you might not have heard of this because if you're following the guidelines, just use our Tayside antibiotic guidelines. But this is from the WHO, and this impacts and filters all the antibiotics that we choose for you as an antimicrobial group. There's antibiotics that are in the access group, that we say give them as your first or second choice. Antibiotics in the watch group that we say, can you kind of not unless you really need to, and then reserve that we're like, definitely do not use these unless an infection specialist has advised it. Now, this is a graph just to show antibiotics in Tayside versus Scotland over time, and you can see that actually we're doing really, really well here. So people are following the guidance and they are using the access antibiotics, and we're actually higher than Scotland. So Scotland's in the black line, Tayside is in the orange line in terms of using the access list. So that's great. That's the right thing to be doing. And the last thing that we've got kind of a push for locally is the primary care prescribing targets. So there's really, really good evidence now that shorter is better. The duration of antibiotic therapy should be much, much shorter. So by 2029, we want 90% of prescriptions of amoxicillin and 60% of prescriptions for doxycycline just to be for a 5-day course for a chest infection. And you can see here that actually NHS Tayside are doing one of the best in Scotland for this. So this is a graph that demonstrates the percentage of antibiotics that are the lowest doses. So when you look at this graph, it looks like it's the wrong way round. It looks like we're giving the most, but we're giving the most of the lowest doses. So our primary care colleagues are doing really, really well here, and that's something that we should encourage throughout the hospital. So I'm going to hand over to my colleague Joanna now, who's going to take you through some AMR surveillance data, and this is a more kind of high-level global detail of what's happening. So over to you, Joanna.
Thank you so much, Helen, and hello to everyone. It's a pleasure to be here. So as Helen said, we are going to have a look globally now to a report that was recently published by the WHO on AMR surveillance. But just to give you an idea what surveillance is basically looking systematically about the patterns of resistance that we see in an organism and how it all looks on a global scale. And next slide. So, sorry, I forgot that. And this is all for us to better understand what is happening to AMR globally, and if there are any things that we might need to kind of observe or change our practice because of like changing resistance patterns or like new antimicrobials becoming less effective that we want that we might want. We also need these data to inform our treatment guidelines. So ideally, all of the hospitals will have their own data, or all kind of the countries will have their own data, and then they can tailor their prescription practices to what they actually see in their setting. This is also data that is going to be used for policy, for planning infection control interventions, and also monitoring the impact on interventions. Yeah, so next slide, please. So just to go to to the GLASS report or the WHO Global Antimicrobial Resistance Use and Surveillance System report. That is a mechanism that supports countries in building national surveillance system. It also provides this data in a standardized way, so we can have comparisons across countries, across regions, and also over time. Next slide, please. And just very quickly how it all works. So there are the various health facilities in various places. That could be like a small practice, could be a district hospital, university hospitals, and they all can contribute data from the microbes that they're getting. And these data get selected by an NCC or a national collaborating center with the help of a reference laboratory, which is a nationally chosen laboratory. And then that kind of data gets cleaned and checked for inconsistencies, and the clean data gets into the GLASS system. Next. Sorry, just a sec. And up to very recently, there were 127 countries worldwide contributing into GLASS. So this is just a map showing the distribution, and we can see all the regions. A lot of countries are contributing data. Next slide, please. And how does this GLASS work? It's not for all of the pathogens. So again, it has to be systematic. So it has a listing of pathogens of interest. And this is just a listing here so for example, E. coli and Klebsiella from the Enterobacterialis, Staph aureus, but also other very important pathogens, a listing of specimen types that need to be monitored, and also a list of antimicrobials, which you'll see on the next slide. So here is the listing for each of the pathogens, their particular antimicrobials that one has under surveillance. Next slide. But of course, I mean, it all sounds very nice and good, but there are issues with surveillance. It's just because the laboratory capacity and the access to diagnosis is not the same overall. So you can see here on this little map, the bloodstream infection isolates that have antimicrobial susceptibility testing results per million population. So basically, how many bacteremias do I have with a positive result and an AST per population of that kind of region or country that that I have. And here we can see that, for example, in high income countries such as like Western Europe or Australia, that number is quite high. So it's about 1,000 isolates per million population. But this is not really the case for low resource settings. Next. And this is because this issues around access. So we have a population, but maybe not in some of the settings where there are issues with accessing healthcare facilities. So people might not be able to reach a facility. People might not be able to be admitted to a facility. People might not have. The doctor might not think about the test. The laboratory might not be able to perform the test, or the laboratory might not be able to report the test. So this kind of thing makes that in some of the settings, this data is incomplete. So the picture that we're having worldwide might not be representative overall, just because of these issues with what kind of data is fed into the surveillance system. Next slide. And this is showing basically the same thing. As you can see in the middle for the European region, it's about 440 overall for the region in terms of coverage. So that means that blood culture isolates with AST per million population. Well, if you look at the African region right at the top, that is much, much lower. So again, we do not have that surveillance, that kind of picture of surveillance from everywhere. Next slide. So this brings me to this report that I mentioned that got recently published, so a month ago, and this report found that that 1 in 6 infections worldwide are caused by resistant bacteria, and overall there is an increase in the AMR by 40% within the previous 5 years. Next. And this version of this data you have also seen just now from Helen. So there are a lot of deaths which are attributed to AMR, over 1 million per year. And this is also listing which are the most common pathogens which are causing these deaths. So the common pathogens which you know from your patients, E. coli, Staph aureus, and Klebsiella, and so forth. Next. And when thinking about, so going back to this class report, when thinking about the problem organisms and the problem resistant that we are seeing on the increase, so that this is globally, it's mainly an increase in carbapenem resistant, which is in mainly in gram negative. So for example, in Klebsiella, E. coli, and Acinetobacter. Next. Next, sorry. Sorry, can you go just before? Okay. So there are two ways to broadly measure resistance based on like SDG, so Sustainable Development Goal indicators. So that includes E. coli from bacteremias with resistant third generation cephalosporins and methicillin-resistant Staph aureus, so MRSA. And again, as mentioned before, we can see that not all the regions are the same. Like as we've seen with surveillance data not being the same globally, it's also resistant data, which is not the same. So Europe has fortunately still very low prevalence of resistance, while the African region and Southeast Asia has much higher resistance. Next, and skip over the next one now, and the next one. And also the pathogens that we see from different regions are not the same. So again, this is a reason why it's very important to actually have data from your specific region and from your specific pathogen, from your specific setting to understand what your problem pathogen are. So this shows the most common pathogens with resistance causing bloodstream infections according to regions, and E. coli, while E. coli is most common in the European and Western Pacific regions with about half the isolates. This is not the picture is quite different in the African region, where you get a lot more of a mixed picture with also a lot more Klebsiella. Next. And please skip over the maps and to the next one. Okay. And at the very end, I just wanted to kind of bring you back to the whole kind of incompleteness of this surveillance data that we have. And this graph shows like the proportion of antimicrobial resistance, or how common resistance is, versus the income of the settings, with lower income settings being in red colors and high income settings being in blue. And on the x-axis, so at the bottom, you can see universal health coverage, that meaning that how easy it is for people to get access to care. So, and again, here we can see that there's a relationship between the prevalence of resistance and access to healthcare and this kind of country income. And this is a mixed reason of that, because of people not being able to access, but also because of potentially increased resistance in these settings. And with this, I would like to thank you. So that's and hand over to Becky, who's gonna talk about one of her patients.
Yep, that's perfect. So thanks, Becky. Do you want to take over from here?
Hi, everybody. So my name is Becky. I am one of the SD5s in ID GIM, and I'm going to talk about a clinical case to try and help bring this into our everyday clinical practice. So I'm going to talk about a 76-year-old woman who was previously relatively fit and well, had a previous DVT, but otherwise really quite well, and had an elective total hip in another surgical centre, and presented 24 hours, 24 to 36 hours post with a history of minor vomiting, but felt like she'd had a pop in her chest and was very short of breath with chest pain. Next slide. This is not the patient's image, although it is basically exactly the same as the patient's image. This is somewhat of a spot diagnosis. So I'll let you guys have a think about what you think that might be. And then we'll go next slide, please. So this is a patient who's had an esophageal rupture, Borhav syndrome, and as we would expect, this was confirmed on a CT with oral contrast, which confirmed the area of the leak for surgical planning purposes. Next slide, please. So, as you can imagine, this is a bit of a nightmare for a whole variety of specialties. So we have a bug that is a normal commensal of the gut, which is an area that is well adapted with its own resistance mechanisms that are intrinsic. So good tight linked junctions that mean that things don't get in or out, designed to be external facing, currently communicating with the pleura, which are none of those things. So there is a surgical chest drain that goes in ED and then is resited because it was moved slightly when the patient was scanned, that drains 600 mils of brown fluid. The patient understandably remains very unwell and unstable, as a lot of these patients are, so they're taken straight to theatre to try and get some source control of this problem. So the patient has an open right-sided thoracotomy, an esophageal repair, external esophageal repair, so that is a suture to the defect that's found in the distal esophagus. It's then checked for airtight seal, isn't sealed and is resutured. And then an esophageal stent is placed in the esophagus to reinforce that repair. They then have a laparotomy, a venting gastrostomy, and a feeding jejunostomy, all under vision. So that is their initial source control operation. Unfortunately, they then have a somewhat stormy post-op course with repeated reaccumulation of fluid, and their total admission is 10 weeks and 2 days. Next slide, please. So this is the first time that we get significant microbiology for this patient. So 18 days post their initial source control operation, they have a chest drain placed by interventional radiology for a reaccumulated pleural collection on that right side, 1.5 litres out. And this is what grows in that. So we have an Enterobacter which is, as I say, a normal commensal of the gut, and then we have a candida. There is, shortly after this, discovered to be a defect in the esophageal stent. So there is a further stent in stent done shortly after this to try and resolve this leak, but there is unfortunately an ongoing leak. Patient's chest drain stays in, and we then get, next slide, please. So from the same chest drain, 11 days later, we have now still got our Enterobacter, which is of something of concern. We now also have a Pseudomonas, and we have an Enterococcus faecium. Enterococcus faecium is a bit of a bugger, really. It's got some intrinsic resistance mechanisms that we don't really like, and they have a high propensity to be resistant to, in this case, amoxicillin. But they can also become vancomycin resistant. This one, thankfully, is sensitive. But that does mean that we have to have a bit more of a think about these than we do about some others. Pseudomonas, as many people will know, is also another one that is quite difficult. Our choices are limited. It readily acquires resistance mechanisms from other bugs. We hate it. And then our Enterobacter that has remained, the eagle-eyed of you will notice that there has been some changes to the resistance patterns here. So this antibiogram has gone from meropenem sensitive to meropenem resistant. And actually, for those who are interested, the MIC, the minimum inhibitory concentration for meropenem, has gone from 1 to greater than 32. A test was put down on a plate and nothing grew. Nothing grew originally, and then everything grew. So this is a big problem. Next slide, please. This is the reference lab report that the clinical team will have received on ICE. I just want you to know that this is very interesting to us, but the only relevant part is the bold at the bottom for most clinical teams, which is that the Enterobacter cobi is a carbapenem-resistant organism, which is not a carbapenemase producer. And it also doesn't produce extended spectrum beta-lactamases. Next slide, please. And what does that even mean? So this is a really excellent figure from a really excellent review from the BMJ in 2016 about antimicrobial resistance in the Enterobacteriaceae. And so the key ones here are about A and about C. So A, the label on the diagram at A is porin, which is the route of entry for most beta-lactams, carbapenems, cephalosporins. They all come in this way because the way that they work is inhibiting cell membrane production, and it prevents the bug from replicating because it can't make new cell walls. And so in order to do that, they need to get into this space, the periplasmic space. So one of the ways that bacteria can increase their resistance to these kind of antibiotics is to reduce the numbers of these porins in their outer membrane. And then the second most significant mechanism for carbapenems, cephalosporins, is what's labeled at C. And this is lysis enzymes. So this is the bacteria producing enzymes which break down the beta-lactam ring of those antibiotics, or other parts of the antibiotic if we're talking about certain types of carbapenemase. In this case, we know that the green enzyme at C is not a carbapenemase or an extended spectrum beta-lactamase. But we also know that the bug is an Enterobacter. So the most likely thing at C is something called AMP-C, ampicillin hydrolyser. And normally that would have almost no effect on resistance to carbapenems. However, bugs have a horrible tendency to combine mechanism A with mechanism C. So if you significantly reduce the amount of antibiotic that's getting into the bug and you lyse some of what is getting in, then you get clinically significant resistance, despite there not being any breakdown specific to the antibiotic that you're using. So this combination is bad, and it's inducible, which is why we saw that big jump in meropenem resistance from being sensitive to being very, very resistant. Next slide, please. So I suppose my final contribution to this is to talk about what we actually do when you contact us. So I was phoned about this patient on a Friday night via ID, and I had to do some thinking. So one of the things that we specifically do is think about what you're asking us. So what infection are we dealing with, and what specific question am I being asked? Then we work out a clinical timeline, factoring in the relevant microbiology and what you've already given the patient. And then we consider some specialist knowledge about antimicrobial resistance. And then we think about your patient bug and drug factors. And finally, we try and make a recommendation that's informed but pragmatic. Next slide, please. This is this patient's antimicrobial journey through their hospital admission. You can probably see that there is some wild stuff on here, and there have been lots of decisions made. The thing I want you to be aware of is that I have to construct this from scratch if you don't give me the information that's necessary to make it happen. There are some unusual antimicrobials on here. So there's ceftaz-avibactam. Ceftazidime avibactam was used to replace the Cotrim and the meropenem in the earlier combination for something a little bit more elegant. The avibactam is a beta-lactamase inhibitor, so it makes the ceftazidime work in a situation where currently the bug is resistant to the ceftazidime alone. It's very expensive and very rarely used. It's one of those very much red antimicrobials that Helen was talking about earlier. So this is a really complex case that tells us something about acquired resistance and a really complex patient, and looks a little bit at what we do as infection specialists for these patients. Thank you very much.
Thanks, Becky. I'm sure that's lots of questions, so we'll try and save them for the end and move on to Anna now, and then hopefully we'll have a little bit of time at the very end, and I'm sure there'll be lots of questions about that patient because they are quite complicated. So Anna, do you want to come on now and talk about the NES AMR framework?
Yeah, thanks. I'm Anna Yahi McDonald. I'm a microbiology consultant in Tayside. but also TPD for higher specialty micro for all of Scotland. And really in that role, I was asked to join the short life working group around creating this framework. And that is for health and social care. I'll talk a bit about how it actually came about in a moment. Next slide, please. So really what we needed is, and looking at the development of antimicrobial resistance, I think it's fair to say that the bugs become resistant faster than people realize what it actually is. And trying to close that gap is really important. Until now, we've often just focused on prescribers because quite logically, they're the ones giving the antibiotics, and that's where it felt that's the one group to focus on. And like Helen said earlier as well, often it's a bit like, well, micro and ID need to fix it, but something I really hope I will show with this framework, it's up to all of us. The framework itself was a bit of a consequence, I would say, probably by the WHO framework and getting more organized around education. Over the last 10 years, I hope everybody's seen in the news, new testing, new antibiotics, how can we finance new antibiotics? And part of that also always of the policy was education, but never quite clear what that actually meant. So we have now developed this NHS Education for Scotland and the Scottish Antimicrobial Prescribing Group have looked into this really carefully, and it was supported by this multidisciplinary short life working group, like I was saying. It was really lovely because we had dentistry there, nursing, medics, infection control, I think it's probably said dental already, but just lots of different people representing very, very different groups of staff. And it was published this August. Next slide. What are the aims of this framework? So really what we wanted to do is go a step wider and raise awareness around antimicrobial resistance, and that's in health and social care. Make everyone aware, especially the people who are then administering the medication, who are changing wound dressings, looking after patients, making sure that the overall care is functioning. We wanted to highlight the need for coordinated action and help staff and students to contribute to this whole antimicrobial resistance topic. So really keeping everyone on board or bringing everyone on board. Our framework is looking at supporting teamwork and joint decision-making, fostering conversations, and really, like earlier, for example, the metronidazole, there's no reason why a nurse can't say, well, this is IV, but can we just have a chat about that? Because I just read and did as part of a framework course that actually metronidazole orally is really quite good. So we can have these conversations, and we really should. So really empowering everybody to be part of how we're keeping our patients safe and how we're keeping our antibiotics going for as long as possible. And then really also supporting educators in creating learning resources and just making it all more fit together. Next slide, please. But then we were there and thought, okay, this hasn't really been done before. There isn't a framework for everyone working in healthcare. How do you even decide who needs what? Who's interested in what area? We cannot ask everyone to do the same course. Something that was a bit tricky for me in the beginning was that the one group it wasn't for is my trainees. So no one who already knows about AMR is really, like, as an introduction, yes, but it's not really meant for them. So I was sitting there not representing my own trainees, but maybe making everybody's work a bit lighter, I guess. So the steps we did was, so first there were stakeholder workshops around who actually needs to be involved in having conversations. Like, for example, who represents dentistry. The next one was a literature review of what's already been done. There's no point in doing another framework like number 15 and nobody's really gone through the first 14. A Delphi study was undertaken, and that was done in a kind of very experienced context Delphi study is referring to a very structured approach to find out from a group of people and experts, either how to get consent on the topic, or in this case, find out all the different opinions on what do they think is what should we focus on, what should we tell people about. We then did a gap analysis of the resources available, where we kind of structured whether or not resources were applicable to us. Did we feel the quality was there? What about updates, feedback loops, all of those aspects? There's a lot of resources out there, and there's a lot of variation whether or not I would recommend them. So that was something we put a lot of work into, and it's ongoing right now. Next step was a draft framework. We then learned about how technically difficult it is to make a framework where you have resources, but lots of different groups accessing the resources. So we'll talk about that in a moment. Came up with a final framework really, and then published it on Turas and started promoting it at meetings with the Scottish Government, who've been supportive the whole way through, but also nursing is really actively promoting it currently, and other groups are joining. Next slide. So how can you find it? Unless you're an ID or microbiology or virology trainee, in which case, please have a look, but not for you. Just joking. The framework is via Turas Learn Zone. Next slide. These are the groups we found really with all the engagement, all the groups also who wanted more information, which I felt was really encouraging. So we have pharmacists, ambulance technicians, a lot of interest there around transporting people with highly resistant bugs, for example, care home managers, care home workers, of course, dentistry, personal assistants, laboratory assistants, physiotherapists, health visitors, GPs, care assistants, staff, nurses, and nursing students. And then really, in the end, it's really for the person we're caring for our patient. Next slide. This is the kind of coding we came up for. So we have our supportive staff, then the non-prescribers, laboratory, pharmacy, nursing and midwifery, and others. There's prescribers of antimicrobials and health and social care staff in management roles. Now, each group and subgroup needs different parts of resources. It needs to be kind of have those direction into which resources are available, but also which ones we rate highly and worth people's time. What we did is that we went through each of the domains and had a look in more detail. Is this relevant? Is this not relevant? And then the whole technical aspect. So if you identify yourself as, for example, being a midwife, you would then go into the midwifery part. And if you go to the next slide, these are the domains that were found to be relevant. These are slightly different, for example, from the WHO framework, because it's not meant for the specialist. So most of the frameworks really have a whole kind of section for specialists or on surveillance. We've not done that, sorry, because we found that that's not really what we're trying to achieve with this framework. We're not trying to say, well, you can only read chapter 1 to 3, but please, the rest is for the experts. That's not the point. The point is really to make sure that everyone feels included in each domain, but has a specific aspect. So domain 1 is really, what is this all about? What's AMR and AMS? What are the foundations? Domain 2 is prevention of infection. And as you can imagine, that's quite important to put that early on. Often, for example, in micro ID training, that's more of an added on. In this case, we've put it very central because a lot of the staff are very actively involved in preventing infection compared to, for example, decision-making on which antibiotics. So that was domain 2. Domain 3 is then diagnosis of infection and clinical decision-making. As you can imagine, that's then more targeted towards prescribers, but also an area that's really important for nursing staff, either because of changing on how prescribing is happening, but also in understanding what antibiotics are given, what the reasons are.
Thanks, Anna. Just to say, we'll probably need to wrap up so that we can get some questions in at the end. Is that okay?
Yeah, absolutely. So domain 5, as you can see, treatment management, and then domain 4, diagnostic stewardship. What is that all about? How do we talk to our teams? How can we work together? And 5 about treatment. Next slide, please. That's what this is going to look like. Everyone is going to get their own list, or is getting their own list, depending on the needs identified. Next one. And then the example here that I thought is quite good is just, we've got posters, really short parts where we suggest how long it will take to work through it, but really to make sure this is not, we're not trying to overload anyone. It's not about being able to regurgitate all the information that's given. It's really about understanding in a practical context what we're doing, why we're doing it, all the extra steps that is needed, for example, for infection control. Next one. And then to finish off, it's really the main parts from this framework is that not all parts, the whole framework is not something that everybody should be working through everything. We've moved away from that. We're really trying to make it as specific as possible, that folk can feel engaged and they really feel that they gained something from going through it. And we're in the process right now of really populating the different staff groups, the content for the different staff groups, but also for everyone. It's really important that staff and line managers discuss what's needed and set clear goals, clear feedback loops to make sure that this is also then put into portfolios and things like that. Implementing learning, that's really the hope, will make a difference, make it practical. And in the end, really, we're in this together. AMR is going to affect us all, is already affecting us all. And we're seeing a marked increase locally as well. Thanks very much, Helen.
Thank you, Anna. So we've just got some take-home points before we move on to any questions. So if you're a prescriber, please make sure you're using the Right Decisions app. You can get it literally just by Googling it. You'll be able to find it. If you haven't already, you can sign up to be an Antibiotic Guardian at the Antibiotic Guardian website, and there's a link there for the Get a Grip framework when prescribing antibiotics. And you've already heard lots about the NES AMR framework. And we've got one little bit of homework for you. So there's a big kind of government focus about public engagement, public awareness. So the more people that know about antibiotics, the more people are likely to use them in a more sensible, sustainable and safe way. So your homework is to tell one non-scientist or non-clinician about AMR. And in that way, if everybody told one person, we'd be spreading that message just that little bit more. So we'll take some questions now. I'll stop sharing my screen so I can see if there's any in the chat. Yeah, and that's us done.
Thanks very much to all of you for that really interesting talk. So there's no questions in the chat right now. Does anyone want to stick their hand up and be brave and ask a question?
Boosie's just put in the chat, just to make sure when you're using the Right Decisions app, you can filter by health board. So you can say like NHS Grampian, NHS Tayside. So just make sure you're using the NHS Tayside one because each of the health boards are a little bit different.
Indeed, I'm looking at it right now. So anybody got any comments or questions?
So,
Tony.
if nobody else, I was when I was looking at that big, was it a committee you did? You're trying to get all the various disciplines on board, all feeding into your work. Did you have a behavioural scientist in it? You know, a psychologist who is.
I think that's the question for Anna, is it? Is that for the NES AMR framework?
Yeah, well, yes, and I suppose more broadly as well about changing behaviour. And did you have a behavioural scientist in who would be saying,
yes,
well, this is how you can, this splendid work you're doing can be more impactful. And that includes amongst doctors, nurses, ambulance staff. specialists, experts, and then members of the public as well. So
Yeah, Anna, do you want to take that?
Yeah, thank you. I think that's a really good question. Yes, we do. And we've been working very closely, for example, with the team at NHS Health Improvement, and really just looking at bringing different expertise on board. And I think, for example, a really important part is we are trying to move away completely from raising fear. What we're trying to raise instead is empowering everyone. And a bit like you said, Helen, just now, like if we all talk about it, if we question, if we feel that dialogue is safe, we can question decision making, we can question sampling happening, not happening. Urine dipsticks, for example, is a big topic again and again. When do we need it? When don't we? And please follow the guidance. But really having that empowering aspect, that everyone has an important role to play. That's that was what we together with behavioral scientists really found out that would be the best way forward.
Thank you. Is there any other questions?
It does not look like it. So
can I just say another
please.
Homework? How many people know what ESBL stands for? You don't have to answer that, but I think it's definitely worth reminding ourselves, kind of.
Well, I could be smug because I know, but I'm sat.
I don't.
I'm an infectious diseases sandwich because I sit between two infectious diseases officers. But extended spectrum beta-lactamases is what they're talking about. Lynn, my next door neighbour, is got her hand up and is waving.
Thank you. Thanks, gang. I was just going to, just as per Becky's slide, where there were a lot of antibiotics and a lot of different organisms, it actually takes us a long time to do a consult for one of these patients, because we have to sit and trawl through what did they have when, what did they grow from, what specimen, which specimens are actually worth treating and which ones are colonizing, all these kind of things. And so it's a bit like lots of things, but these often come through at like 3:30 on a Friday. This person who's been in for 9 months, we've decided they're well enough to go home. Please, could you give us an antibiotic plan? And it's just not possible, because to do it properly, we have to spend time. And sometimes we have to ask the lab for other things and set up other things. So it's just to recognise it actually takes us a long time to come up with a plan for these complicated patients, and just to give us a bit of time and recognise it might take us 3 days, because we may have to go back to the lab and ask for more info, or sometimes longer than that. For example, if it's fungal, we have to go to the ref lab in Bristol to get sensitivities, etc. So sometimes information we can't be as quick as maybe you would like us to be, and therefore if you have that in your mind that you might be sending someone home who's been super complicated, let us know the week before they go home, not the afternoon of discharge, because we can give you a better informed plan.
Lee from my next door neighbour, and Becky has a comment, and I think we'll then close the meeting. Becky?
Yeah, absolutely. And just to echo that, so I'm kind of trying to demonstrate the amount of work that we do on these cases, because it is a reasonable amount. But the other thing I'd say is that if you were, so the specific query I was asked about this patient on a Friday was, what are our IVOST options, our oral switch options for a patient who had been on ceftazidime-avibactam, which is already a sign that there isn't probably going to be a simple combination. So I would generally say that we don't tend to IVOST our patients on a Friday if we can avoid it. Like, we would have done it earlier so that we know that it's all going to be okay by the weekend. If you're making a complex IVOST choice, probably don't do it on a Friday afternoon if you can avoid. Pick another day.
Indeed. Right, so I'm just looking at the chat and there is nothing else in there. So it just remains for me to thank those who spoke today, and for those of you who've stayed on to listen, and to thank you if you're listening and watching this on our YouTube channel. Next week, Sarah Alstoff is going to speak about, and I don't know the title of her talk. It's an HIV themed talk. It's HIV Awareness Week, and she's going to come and speak about something HIV related. Her talks are always very interesting, so I recommend coming along to that. It will be again on Zoom. If you would like to give a talk at Grand Rounds, there are slots in 2026. And I have the timetable up on my other screen, so I'm happy to slot you into a slot from starting in the middle of January all the way through until July. So if you've got a talk in your back pocket, or you know someone who could give a good talk, then please do let me know, and we'll try and give you a slot on the rota. Other than that, thanks very much to our speakers. Thanks to you for turning up, and I will see you again next week.